Hello, everyone. Welcome to A4 Medicine. This is your host, Rahul Srivastav, and we're discussing the topic menopause, identification, and management in primary care. A gentle warning before we begin: menopause can feel like a complex topic. There are several items, treatment options, prescribing decisions, and risk discussions to understand. So, this session is slightly longer than usual. Please bear with us because by the end, you should have a practical framework that makes menopause consultations much easier. We will cover the underlying physiology, clinical diagnosis, appropriate testing, symptom management, HRT selection, risk counseling, and follow up based on the NICE guideline numbered NG23. The aim is not simply to memorize preparations, it is to understand why each decision is made so that you can apply the guidance confidently in everyday general practice and in the RCGP AKT. Menopause is not a single event, it's a transition caused by declining ovarian follicle function. The ovaries normally produce estrogen, progesterone, and inhibin. As the number of functioning follicles falls, production of these hormones become irregular and eventually remains low. During perimenopause, estrogen may fluctuate considerably rather than falling smoothly. This explains why menstrual cycles and symptoms can be unpredictable. Perimenopause is the period when menopause related symptoms and menstrual changes begin. Menopause itself is reached after 12 months without a menstrual period, provided hormonal conception is not masking the cycle. Symptoms may include hot flushes, night sweats, sleep disturbance, mood change, vaginal or urinary symptoms, joint pains, cognitive concerns, and altered sexual function. The consultation should therefore consider symptoms, personal and family history, lifestyle, treatment preferences, and how these factors may change over time. About the diagnosis in an otherwise healthy person aged 45 or over, perimenopause and menopause should usually be diagnosed clinically without routine blood tests. Perimenopause, as we discussed, is suggested by recently developing vasomotor symptoms, meaning hot flushes or night sweats, together with a change in the menstrual cycle. Menopause is diagnosed after at least 12 months without a period, provided the person is not using hormonal contraception. Following hysterectomy, periods cannot guide diagnosis. So consider age, symptoms, and whether the ovaries were removed. Now, why do we avoid routine hormone tests? FSH and estrogen levels fluctuate during perimenopause. A normal FSH does not exclude perimenopause, while a raised result may fall again. Do not routinely use FSH, estradiol, anti-mullerian hormone, inhibin, or ovarian imaging to diagnose menopause in healthy people over 45. So, in practice, typical symptoms at 45 or over usually means a clinical diagnosis. Do not routinely order hormone tests. Targeted testing for early menopause and premature ovarian insufficiency. Testing becomes more important in younger people. Between ages 40 and 45, consider serum FSH when menopause related symptoms occur with menstrual change. Menopause between 40 and 44 is described as early menopause. Under 40, consider premature ovarian insufficiency. We call it POI from here on. This means ovarian function has reduced much earlier than expected. The physiology explains the raised FSH. When the ovaries produce less estrogen and inhibin, negative feedback to the pituitary falls. The pituitary responds by releasing more FSH in an attempt to stimulate the ovaries. Diagnose POI using compatible symptoms, usually absent or infrequent periods, together with raised FSH on two blood samples taken 4 to 6 weeks apart. Do not diagnose POI from one result and do not routinely use anti-Mullerian hormone. Also consider pregnancy, hormonal medication, thyroid or prolactin disorders, previous chemotherapy, radiotherapy, ovarian surgery, autoimmune disease, and family history. So, in practice, under 40, suspected POI requires the clinical picture plus two raised FSH results 4 to 6 weeks apart. In the management toolkit, let's focus on thinking of menopause management as three complementary pillars. The first is systemic HRT. Systemic means that the hormone enters the bloodstream and acts throughout the body. It is the principal medical treatment for symptoms such as hot flushes and night sweats. The second is menopause specific cognitive behavioral therapy or CBT. CBT does not suggest that the symptoms are imaginary. It helps patients modify thoughts, behavior, and physiological responses that can amplify flushes, poor sleep, and emotional distress. The third pillar includes local and non hormonal treatments. Examples include vaginal estrogen, moisturizers, lubricants, and selected non hormonal medicines. These options are not mutually exclusive. Vaginal estrogens can be used with systemic HRT, and CBT can be combined with medical treatment. Warn patients that the purity, dosage, safety, and medicine interactions of unregulated compounded hormones and some complementary preparations may be uncertain. Now, you need to we should always try to tailor treatment to the symptom profile. Begin by asking which symptoms are having the greatest effect on the patient's life. For hot flushes and night sweats, systemic HRT is usually the main treatment when suitable. For vaginal dryness, painful sex, irritation, or urinary discomfort, local vaginal treatment may be needed, even when systemic HRT is already being used. For sleep problems, low mood, and vasomotor symptoms, menopause-specific CBT can be used alongside HRT or when HRT is unsuitable or unwanted. Ask sensitively about sexual function. Pain may result from vaginal dryness, while low desire may also involve mood, medication, relationship factors, or hormonal change. Testosterone may be considered for persistent low sexual desire associated with menopause when HRT alone has not helped. Also, discuss physical activity, muscle strength, bone health, smoking, alcohol, and contraception. Remember that HRT does not provide contraception. In practice, match treatment to the dominant symptoms, but remember sexual health, bone health, and contraception. Vasomotor symptoms are hot flushes and night sweats. Falling estrogen affects the hypothalamus, the part of the brain that regulates temperature. The body's comfortable temperature range becomes narrower, so a small temperature change can trigger flushing, sweating, palpitations, or chills. Offer HRT when it is suitable and acceptable to the patient. Menopause specific CBT may be added to HRT or used when HRT is contraindicated or declined. It can also help sleep problems caused by repeated night waking and night sweats. Fezolinetant is a known hormonal medicine that blocks neurokinin signaling within the brain's temperature control pathway. NICE recommends as it for moderate to severe vasomotor symptoms when HRT is unsuitable. Fezolinetant can cause liver injury. Check liver function before treatment, monthly for the first 3 months, and periodically afterwards. Do not routinely use SSRIs, SNRIs, or clonidine as first line treatment for vasomotor symptoms alone. Not every episode of low mood during menopause is clinical depression, but depression must not be missed. Menopause associated depressive symptoms may include tearfulness, irritability, reduced confidence, or low mood, beginning alongside menstrual change, disturbed sleep, and vasomotor symptoms. They do not meet the full severity, duration, or functional criteria for a depressive disorder. HRT may be considered when these milder symptoms begin around the same time as other menopause symptoms. Menopause specific CBT is another evidence based option. Clinical depression is different. Ask about persistent low mood, loss of interest, impaired functioning, guilt, hopelessness, self neglect, and suicidal thoughts. When depression is suspected or diagnosed, follow the NICE depression guideline while also addressing menopause symptoms. Do not assume every mood change is hormonal, but do not overlook menopause as a contributing factor. In practice, menopause related low mood may respond to HRT or CBT, but suspected depression requires a full mental health and suicide risk assessment. Menopause specific CBT is a structured treatment adapted to common menopause related difficulties. For hot flushes, it helps patients identify thoughts such as embarrassment, fear, or loss of control and develop more helpful responses. For sleep disturbance, it addresses nighttime worry, irregular sleep routines, and behaviors that maintain insomnia. Repeated night sweats may cause anxiety about not sleeping, which then makes sleep more difficult. For depressive symptoms, CBT identifies unhelpful patterns of thought and behavior and supports gradual re-engagement with everyday activities. It can be delivered face to face, remotely, individually, in groups, or through supported self help. Explain that CBT is not being offered because symptoms are all in the mind. It is an active, evidence based treatment that can reduce the distress and disruption caused by genuine biological symptoms. It can be used with HRT rather than only instead of it. Genitourinary symptoms associated with menopause include vaginal dryness, burning, irritation, pain during sex, and discomfort when passing urine. Urgency and recurrent urinary infections may also occur. Reduced estrogen causes vaginal, vulval, and lower urinary tract tissues to become thinner, drier, less elastic, and more vulnerable to irritation. Unlike hot flushes, these symptoms often persist or worsen without treatment. Offer vaginal estrogen to most patients with genitourinary symptoms, including those already taking systemic HRT. Systemic treatment does not always provide enough relief to the local tissues. Vaginal estrogens can be combined with moisturizers, which are used regularly for background dryness, and lubricants, which can reduce friction during sexual activity. For someone with previous breast cancer, start with non hormonal moisturizers or lubricants and consider vaginal estrogen if symptoms continue, using individualized discussion and specialist involvement where appropriate. Do not offer laser treatment outside a randomized controlled trial. Before continuing, a brief learning resource note. Many principles in this session, hormonal feedback, bone health, metabolic risk, and endocrine prescribing, form part of a wider endocrinology knowledge required for the RCGP, AKT, in everyday primary care. The A4 Medicine book, Metabolic Problems and Endocrinology, is evidence based revision and practical reference guide. It covers diabetes, thyroid disease, osteoporosis, bone health, adrenal condition, lipid disorders, and other commonly tested endocrine topics. It is designed for rapid recall, clinical consultations, and AKT preparation, and includes 12 months of A4 Medicine access with each purchase. The book is available through Amazon, including Amazon Prime, where eligible. We'll now return to the clinical pathway and look more closely at vaginal estrogen and genitourinary care. Vaginal estrogen is low dose local treatment. Preparations include creams, gels, tablets, pastries, and vaginal rings. Choose the formulation according to preference, dexterity, convenience, and availability. A ring, for example, may suit someone who finds frequent applications difficult. Only a minimal amount is absorbed into the bloodstream compared with systemic HRT, and serious adverse effects are very rare. Vaginal estrogens can be used alone, alongside systemic HRT, or with non hormonal moisturizers and lubricants. Explain that improvement may take several weeks and that symptoms often return when treatment stops. Treatment can be restarted and may be required long term with regular review. When vaginal estrogen is contraindicated or declined, consider non hormonal moisturizers and lubricants. If these options are ineffective or not tolerated, vaginal prasterone may be considered. Ostamafine is an oral option when local application is impractical, for example, because of disability. In practice, vaginal estrogen has minimal systemic absorption and can be usually used alongside systemic HRT. Now, regarding genitourinary symptoms after breast cancer, for someone with a personal history of breast cancer, use a stepped and collaborative approach. Begin with non hormonal moisturizers and lubricants. If symptoms persist and significantly affect quality of life, vaginal estrogen may be considered rather than automatically refused. Vaginal estrogens act mainly locally, although a small amount reaches the bloodstream. For previous estrogen receptor negative breast cancer, NICE advises that small systemic exposure is unlikely to increase recurrence risk. For estrogen receptor positive cancer, the effect on recurrence remains uncertain. Tamoxifen blocks the estrogen receptors in breast cancer cells and may reduce the potential effect of absorbed estrogen. Aromatase inhibitors work differently. They reduce estrogen production to very low levels. If the patient is currently taking an aromatase inhibitor, work with the breast cancer specialist before considering vaginal estrogen. Balance symptom severity, cancer recurrence risk, current treatment, and informed patient preference. The genitourinary care pathway. This slide brings the pathway together. With no breast cancer history, often vaginal estrogen, and choose the formulation with the patient. Add moisturizers or lubricants when useful. If vaginal estrogen is ineffective, or not tolerated, consider vaginal progesterone. Progesterone is a hormone precursor placed in the vagina and converted mainly within the local tissue. When local treatments is impractical, consider oral ospemifene. Ospemifene is a selective estrogen receptor modulator. This means it produces estrogen like effects in some tissues without acting exactly like estrogen throughout the body. With previous breast cancer, start with non hormonal treatments. If symptoms continue, consider vaginal estrogen through shared decision making. For estrogen receptor positive cancer, uncertainty remains. For patients taking aromatase inhibitors, collaborate with the breast cancer team. Review effectiveness, tolerability, and any unexpected vaginal bleeding. This chart shows the systemic HRT prescribing decision tree. The first systemic HRT question is: does the patient have a uterus? Estrogen stimulates the endometrium, which is the lining of the uterus. Unopposed estrogen can cause excessive endometrial growth and increased endometrial cancer risk. A patient with a uterus therefore needs combined HRT, estrogen for symptom relief, plus a progestogen to protect the endometrium. After a total hysterectomy, there is no endometrium to protect, so estrogen only HRT is usually appropriate. Seek a specialist advice in more complex situations, including subtotal hysterectomy, previous endometrial ablation, significant endometriosis, or another condition that may be affected by HRT. The next decision is the route. Transdermal estrogen is delivered through the skin as a patch, gel, or spray. Prefer it when venous thromboembolism risk is increased, including a BMI above 30. Use the lowest dose that adequately controls symptoms. Choosing type, route, and regimen. HRT prescribing involves three separate decisions: hormone type, route, and regimen. Type depends mainly on the uterine status. As we discussed, use combined HRT when the uterus is present and estrogen only HRT following total hysterectomy. Route means oral tablets or transdermal patches, gels, or sprays. Oral estrogen passes through the liver before reaching the main circulation. This is known as the first pass metabolism and affects the production of clotting proteins. Transdermal estrogens avoids this first pass effect. Regimen determines the bleeding pattern. Sequential or cyclical combined HRT gives estrogen every day and progesterone for part of each month. It is generally used during perimenopause and normally produces a planned withdrawal bleed. Continuous combined HRT gives both the hormones every day. It is generally used after menopause and aims for no planned monthly bleed. Starting continuous combined HRT while ovarian activity continues may lead to irregular bleeding. In practice, sequential HRT produces plant bleeds in perimenopause. Continuous combined HRT is generally used after menopause. We have to look at the risk equation, vascular and neurological profiles. Venous thromboembolism or VT includes deep vein thrombosis and pulmonary embolism. Oral estrogen passes through the liver and alters clotting factors, including VTE, increasing the VTE risk. Transdermal estrogens does not increase VTE risk according to NICE and is therefore preferred when baseline clot risk is higher. High risk patients, such as those with strong family history of known thrombophilia, may require hematology assessment before HRT. Oral HRT also increases stroke risk, particularly with increasing age, higher estrogen doses, and longer exposure. Transdermal estrogen is unlikely to increase stroke risk. Apologies for the pause. I had to put a power cord. Similarly, do not prescribe HRT specifically to prevent dementia. Combined HRT started at age 65 or over may increase dementia risk. A history of coronary disease or stroke requires assessment by a clinician with menopause expertise. So, in practice, oral HRT increases clot risk. Transdermal estrogen is generally safer when vascular risk is higher. Regarding breast and endometrial cancer risk, breast and endometrial cancer risks are different. So, do not group them together as one general HRT cancer risk. Combined HRT is associated with increased breast cancer incidence. The increased risk with duration is greater during current use and declines after stopping, although some increased risk may persist. Sequential combined HRT carries a lower breast cancer risk than continuous combined HRT, but a higher risk than no HRT. Current evidence does not establish that micronized progesterone or dihydrogesterone has a different breast cancer risk from progesterogens. Estrogen only HRT, used after total hysterectomy, produces very little or no increase in breast cancer risk. Endometrial risk works differently. Estrogen only HRT in someone with a uterus increases endometrial cancer risk. Continuous combined HRT reduces that risk through daily progesterone protection. Sequential HRT may slightly increase endometrial risk, particularly with longer treatment, insufficient progesterone exposure, or higher estrogen doses. Practice point: combined HRT affects breast risk. Unopposed estrogen affects endometrial risk. Do not confuse the two. When discussing HRT, place each outcome against the patient's baseline risk. For breast cancer, combined HRT increases risk, while estrogen only HRT causes very little or no increase. For endometrial cancer, continuous combined HRT provides protection. Estrogen only HRT should not be used when uterus is present. Ovarian cancer is much less common than breast cancer. NICE describes a very small risk in risk with increase in risk with HRT, but the absolute risk remains low, particularly in younger patients. HRT reduces fragility fracture risk while it is being taken because estrogen slows bone resorption, the process by which bone is broken down. This benefit decreases after treatment stops, although it may continue longer after longer treatment. Bone protection is particularly important in premature ovarian insufficiency and early menopause because the patient may otherwise have many additional years of low estrogen exposure. The decision is therefore not simply that HRT is safe or dangerous, it depends on age, uterine status, root duration, and baseline risk. So, contextualizing systemic HRT risk, shared decision making means neither recommending HRT to everyone nor frightening patients away from it. Overall, using combined or estrogen only HRT for menopause symptoms is unlikely to alter life expectancy. Do not prescribe HRT specifically to prevent cardiovascular disease or dementia. Instead, prescribe it for appropriate menopause symptoms after discussing individual benefits and risks. Root matters. Oral HRT increases VTE risk, while transdermal HRT does not. Age, BMI, smoking, alcohol intake, family history, previous thrombosis, and cancer history all influence baseline risk. Whenever possible, use absolute numbers rather than vague terms. Relative risk describes how much a risk changes proportionately. Absolute risk explains the patient's actual chance of an outcome. For example, how many additional cases may occur per 1,000 people. This usually provides a clearer and less alarming risk discussion. Complex and special situations, three groups require particular consideration. First, premature ovarian insufficiency under 40. Unless contraindicated, offer sex steroid replacement using HRT or a combined hormonal contraceptive and continue until at least the usual age of natural menopause. They support symptoms, bone health, and cardiovascular health. Remember that HRT is not contraception. Risk counseling in POI differs from counseling someone starting HRT at 50 because treatment in a younger person is replacing hormones that would normally still be present. Second, trans men and non binary people, registered female at birth who have previously used gender affirming hormones should have access to appropriate menopause expertise. Third, anyone expecting medical or surgical menopause should be offered discussion about fertility and menopause before and after treatment. Surgical removal of the ovaries causes a sudden fall in hormones and may produce abrupt symptoms, unlike the gradual transition of natural menopause. Reviewing treatment, menopause treatment should not be prescribed and forgotten. Review each treatment after 3 months. At this appointment, assess whether symptoms have improved, whether adverse effects are acceptable, and whether the patient is using the treatment correctly. Ask about bleeding, breast symptoms, headache, skin reactions, mood, and any new medical problems. Check whether the charity dose, route, and regimen still suit the patient. For gels or sprays, ask about application technique and adherence. For patches, ask about adhesion and skin irritation. Revisit contraception where relevant and encourage nationally recommended health screening. After the initial review, review treatment annually unless symptoms are uncontrolled, adverse effects occur, or another clinical issue requires earlier assessment. At each review, reassess the balance between benefit and risk rather than assuming the original decision remains appropriately indefinitely. Unscheduled bleeding on HRT. Bleeding must be interpreted in relation to the HRT regimen and when treatment begins. A planned monthly withdrawal bleed is expected with sequential combined HRT. Unscheduled bleeding means bleeding that occurs outside the expected pattern. In someone with a uterus, irregular bleeding is common during the first 6 months after starting systemic HRT and during the first 3 months after changing the dose or preparation. Explain this before treatment so the patient knows what may be expected. Bleeding beyond these timeframes require prompt medical assessment. Also assess earlier if bleeding is heavy, prolonged, occurs after sex, is associated with pain, or the clinical picture is otherwise concerning. Check the HRT regimen, adherence, and whether adequate progesterone is being used. Consider cervical, vaginal, and endometrial causes rather than assuming all bleeding is caused by HRT. Follow the relevant local and suspected cancer pathways when investigation is required. In practice, bleeding is commonly expected for 6 months after starting HRT or 3 months after a change. Beyond that, assess promptly. There is no single correct way to stop the HRT. Offer the patient a choice between stopping immediately and reducing treatment gradually. Gradual reduction may reduce symptom recurrence in the short term. However, in the longer term, tapering and immediate cessation make little difference to whether symptoms return. If symptoms recur and remain troublesome, reassess their cause and discuss whether treatment should be restarted, modified, or replaced with another option. The decision to continue or stop should be based on the patient's current symptoms, preferences, health risks, and treatment benefits, not simply on reaching a particular age. Systemic HRT should be stopped if breast cancer is diagnosed, with further menopause management coordinated through the breast cancer and menopause teams. Local vaginal symptoms may still need treatment, but this requires an individualized plan based on the cancer type and current therapy. The whole menopause care pathway bring the consultation together as a continuing care pathway rather than a one-off prescription. First, establish whether the presentation is consistent with perimenopause, menopause, early menopause, or premature ovarian insufficiency. Secondly, identify the dominant symptom groups: vasomotor, psychological, sleep related, genitourinary, sexual, or musculoskeletal. Third, consider relevant medical history, family history, contraception, fertility, baseline cardiovascular risk, and cancer risk. Fourth, agree treatment. This may include systemic HRT, menopause-specific CBT, vaginal estrogen, non-hormonal treatment, lifestyle support, or a combination. Fifth, explain expected benefits, possible adverse effects, bleeding patterns, and when to seek help. Finally, review at 3 months and annually, adopting the plan as symptoms, priorities, and risk factors change. Good menopause care is dynamic because the transition itself and the patient's circumstances evolve over time. When to refer and seek specialist advice, most menopause care can be delivered confidently in primary care, and but we recognize when additional expertise is needed. Refer or seek advice when the diagnosis of premature ovarian insufficiency is uncertain, particularly in someone under 40. Seek menopause expertise when HRT is contraindicated, the most appropriate treatment is unclear, symptoms remain uncontrolled, or adverse effects persist despite adjustment. Complex histories include previous hormone dependent cancer, high familial cancer risk, current aromatase inhibitor therapy, previous coronary disease or stroke, strong VTE history, or known thrombophilia. Planned medical or surgical menopause may require fertility, oncology, gynecology, or specialist menopause input. Also, seek advice when the patient has had subtotal hysterectomy, endometrial ablation, significant endometriosis, or another condition that may be affected by HRT. Referral is not a failure of primary care, it is part of safe, coordinated management. Thank you for watching this video presentation on menopause management. I hope this was useful. For further such videos, please like and subscribe to our YouTube channel and visit our website for further educational material, MCQs, AKT MCQs, and books. Thank you.